Hello, hello. Hello, sir. Hello. System पे जाना क्या है मोबाइल ले जाना ಮಾತಾಡ್ ನೋಡ ನನಗೆ ಬರುತ್ತೆ ಹಲೋ हेलो हेलो
ಓ ಅಲ್ಲಿ ಹೋಗಿ ಮಾಡ್ಯಾರ
A very good afternoon to everyone. A warm welcome to all the one who have been joined this meeting offline and online. So we have joined this meeting today to enhance our knowledge from the one of the renowned knowledgeable person, Dr. Parikshit, sir, who is going to share his knowledge in the management of COVID-19 for the next few hours. So it's our opportunity to gain the knowledge from such a knowledgeable doctor. So I would like to welcome Dr. Parikshit Prayag, sir. So he's been certified from American Board of in Internal Medicine from Rutgers University, New Jersey, and he's been also certified from American Board in Infectious Disease from Anderson Cancer Center, Hudson, and he's been also certified in American Transplantation Society in Transplant Infectious Disease, Stanford University, California. So he is a section editor in infectious disease in Indian Journal of Medical and Pediatric Oncology. He is a reviewer in Indian Journal of Critical Care Medicine, and he is a visiting faculty in Tata Memorial Hospital, Navi Mumbai. And he is the only trained transplant infectious disease consultant in India. So it's our honor and opportunity to have such a great personality among us and gain a knowledge from him. And I would like to welcome our medical superintendent, Dr. R.M. Onantigi sir, who stands always and as a backbone for the development in the students' curriculum and hospital. So I welcome Dr. Parikshit Prayag sir to share his knowledge in. Hello.
Okay. Can you hear me?
Yes, sir.
Yes. So once again, good evening to everyone, and we are extremely sorry for the delay. We had some technical issues in trying to set up our computers and the internet. So again, thank you so much, and it's my great honor and pleasure to join with you this evening. So we already have people from your department visiting us, and they're going to be here for the next 2 or 3 days. So is my audio and video clear?
The video is not this.
Clear, sir.
Oh, yes. ऑन करने को अभी शेयर करने को बोलिए.
You just give us 1 minute, please.
Yes,
we are
sir.
trying to connect to a better network. PG students or UG students?
PG students. Anesthesia and medicine.
Disconnected.
Yeah, hi, can you hear me?
Yes, sir. Yes, sir.
Okay. Yeah, so once again, our sincere apologies. We've been having a lot of technical issues, but I hope the internet is a little bit better now. So I'll just start by sharing my screen. Okay, can everyone see my screen?
Yes, sir. Yes, sir.
Okay. So once again, good evening, everyone. We have a few people here. We have our own ID department, and of course, the visitors from your college. So once again, thank you for the opportunity. So in the what we are planning to do is in the first 30 minutes or so. Yeah, I think the screen is clear. There was some problem. Can you see this little box on the screen?
Yes, sir.
Okay, I'm trying to get rid of that box. Yeah. So what I'm going to try and do is, in the first 30 minutes or so, we're going to talk about, the current perspectives of the management of COVID-19, and also tell you some of the things that we've been doing here. We've had more than 20,000 COVID patients now since the start of COVID in March last year. Uh, these are my conflicts of interest. I work on the advisory board for Cipla, Pfizer, Abbott, Glenmark, Mylan, and MSD. So if you look at COVID-19, there are a lot of problems when it comes to straightening out the therapy for COVID-19. In most of the things that we do for COVID, there is a little bit of everything that I've shown on this slide. There is a little bit of evidence, there is a little bit of anecdotal approach, there is definitely some amount of rationale, and at the end of the day, we are trying to sort of balance the risk versus benefit. And in India, another very important question is, how much does this therapy cost? So, for example, if you look at steroids, then there is a fair amount of evidence and good amount of rationale. There is also very good anecdotal experience now with steroids. Cost is also very, very minimal, but then it doesn't tick the box of risk versus benefits. So we have to be careful with that. On the contrary, if you consider something like remdesivir, cost might be an issue. Anecdotally, most people have had good experiences. Rationale is decent, but the evidence is not very robust. So when it comes to COVID-19, trying to tick all these boxes becomes very difficult. And that's why if you look at the pathophysiology of the disease, we have to ask ourselves, what are the drugs that we are giving according to the phase of the viral infection. So, most viral infections, what they or how they start is that they have an initial prodrome, and then most upper respiratory viral infections attach to the upper respiratory epithelial lining, and then they sort of proceed to the lower respiratory lining or the alveolar epithelial lining. Now, what's different about COVID is that apart from the epithelial attachment, it also causes endothelial damage. And that's why you have a virus that is now eliciting a fair amount of inflammatory response. It's also causing, capillary damage, and it is also causing hypercoagulability. So when it comes to, your viral phase, in the first week of the illness, mostly you will have your viral phase. So the virus will attach to the ACE receptors and then will travel downwards, and then will start causing damage in the alveolar epithelial and the endothelial lining. In the second week, you have an inflammatory phase, which again exists for most viral infections. There is an inflammatory phase for flu. There is an inflammatory phase for CMV. It's just that it is not as pronounced as it is for COVID-19. And that is why we initially started toying around with the idea of, using anti-inflammatory agents in this phase. So it really depends on what your patient is having as the underlying pathophysiology. So for example, if my patient worsens on day 10 or day 12, I have to ask myself, is this direct viral damage, or is this inflammatory damage, or we are having some other secondary complications like hypercoagulability or secondary bacterial infections, secondary fungal infections, is there myocarditis? So that's why every patient is different, So for someone who is worsening on day 10, you might find some patients who are in the hyperinflammatory phase. So your therapy is going to be giving them anti-inflammatory agents. There might be some who are now having secondary bacterial infections. So if for those you use if you keep on upgrading the anti-inflammatory agents, you actually might be harming the patient. Conversely, every patient who is worsening will not require secondary antibacterial medicines. Otherwise, you are not being a good steward. And we have already seen a gross misuse of antibiotics across the country in COVID-19. Most of you must have read this article, but I think in India, the antibiotic misuse has been the highest across the pandemic. So antibiotic sales have more than tripled across the country in COVID-19 in the last 1.5 years. So this is something that we need to guard against, because at least in our center, things might be a little bit better at your place, because I'm sure you don't use higher antibiotics as much as we use it in the private sector. But still, on a national scale, we are seeing a fair amount of gram-negative resistance when it comes to post-COVID infections. So with this, I'll be mainly talking about I'll be talking about specific therapies, because I'll be taking only about 30 minutes, and then my fellow is going to be presenting 2 or 3 cases. So I'll be talking about remdesivir, monoclonal antibodies, steroids, and which ones are we using, what has been our experience, what doses are we using it in, what durations are we using it, what is the evidence behind that. Totalizumab, JAK inhibitors, which have now increasingly come into the COVID protocol, for example, baricitinib or tofacitinib, and then some of the other experimental drugs that we are not using to a great extent, at least at our center, but we'll try and discuss what the evidence is for some of these drugs. So starting with remdesivir. So remdesivir is actually meant to be a generalized RNA inhibitor. So it is meant to be a generalized inhibitor for RNA viruses, and it was originally used during the Ebola pandemic, 5 years back. But by the time we could design proper randomized control trials for remdesivir, we had Ebola monoclonal antibodies, and that is how remdesivir fizzled out. And then Ebola fizzled out before we could have or generate more evidence. So it is not a specific COVID-19 drug. It's a drug which is meant to target the RDRP region of the COVID-19 RNA. So what that means that it is likely to be effective across a broad range of RNA viruses, but it's not a specific COVID-19 therapy. So far, we have had this huge ACTT trial, which I am sure all of you must have seen. And what they showed was that this is the NEJM trial. What they showed was that patients who were on low flow oxygen, or patients in whom the lower respiratory involvement had just started, these were the patients that benefited most from remdesivir. So, someone who was absolutely stable on room air, young patient, you have no evidence of lower respiratory infection, remdesivir doesn't help to a great extent. Someone who is on mechanical ventilation, remdesivir may not help to a great extent. But what they showed was that patients who are on low flow oxygen or patients who have high grade fevers with evidence of lower respiratory involvement, there was disease shortening. Subsequently, there has been some work done actually from Bangalore and more recently from Ahmedabad, in which they have shown that there could be some mortality benefit in these patients, and in these papers are still in the pre-print phase. So we had collaborated with one of the centers in Ahmedabad Care Hospital, and this is in the process of being published. But what they have shown is that in their almost 2,000 to 3,000 patients in whom remdesivir was used, and they analyzed this data retrospectively. So it was a retrospective study in which they looked at remdesivir versus placebo. What they showed was that it does offer even mortality benefit in patients who are on low flow oxygen. But the bottom line here is that this is a direct viral inhibitor. So this needs to be used in context. This is very rarely useful when we use it, let's say day 12, day 13 onwards. So in the first 10 days, if you have someone who is coming in with direct viral progression, so with a substantial amount of CT damage, early hypoxia, that is the time remdesivir is really supposed to be useful. One of the questions is, and I'm sure that the remdesivir usage across the country has been fairly uniform. Most hospitalized patients, unless contraindicated at most centers, remdesivir is being used liberally. In our center, what we do is that if there is early evidence of hypoxia, which means that you make the patient walk for about 3 to 6 minutes and he drops his saturation to below 93%, or if there is high grade fever with lower respiratory involvement, that is the time we use remdesivir. But there is another school of thought that these antiviral agents need to be used really early in the course. So in some centers across the world, and in actually many centers across India, what people are doing with remdesivir is that any patient who is sick enough to be hospitalized gets remdesivir. So for example, you have hospitalized the patient for any other reason. Maybe he's a very high risk patient, let's say uncontrolled diabetes, obesity, or a transplant patient, immunocompromised, and he's sick enough to be in the hospital. Let's say his baseline CRP is more than 60. So you feel that this patient should be watched in the hospital, or is symptomatic or sick enough to be in the hospital. Some centers use remdesivir. And again, that's not a wrong approach, because, although the ACTT trial showed that patients who were not really hypoxic or did not have lower respiratory involvement did not benefit much, but that's not to say that this is a wrong approach. Like I said, for COVID-19, we have to take a little bit of everything, evidence, anecdotal, risk versus benefits, and pathophysiological rationale. So the pathophysiological rationale tells us that this should be used in the first 7 to 10 days, and it should be used early in the course for patients who are likely to get sick or who have substantial lower respiratory involvement. Another interesting scenario is someone who has a CT score of 18 or 19, but is completely clinically stable. So I have had patients in my OPD, who have walked in with their CT scans already done, day 7 of illness. Patient is completely asymptomatic, but he has a score of 18 or 19. So this is a high risk patient for progression, high risk patient for subsequent fibrosis, high risk patient for developing hypoxia. Do you use remdesivir in such patients? I personally don't, but it's not wrong to consider remdesivir when you have substantial lower respiratory involvement. Usually in our hospital, we do not decide remdesivir usage based on the CT score. But it's like I said, if there is pathophysiological rationale, then it's not incorrect to use remdesivir. But one of the recurring questions about remdesivir has been, the duration of remdesivir and the toxicity of remdesivir. So initially, when we started using remdesivir last year, it was, I think, June of last year when remdesivir became available in India. We had kept the GFR cutoff as 30 for using remdesivir. So anyone who had a GFR of less than 30, we did not use remdesivir. Subsequently, there have been some good reviews published, and this the best one is probably from the Journal of Nephrology, the American Journal of Nephrology, in which they have described the in vitro evidence, which means the animal model experience as well as the human experience as far as nephrotoxicity with remdesivir is concerned. Now, remdesivir itself is not very nephrotoxic because it's a weak inhibitor of the human DNA and RNA. So unlike what it does to the COVID-19 virus, it will not play around with our own DNA. So it's a weak inhibitor of the mammalian DNA. So it has low potential for mitochondrial toxicity. which means that, remdesivir itself is not going to be very nephrotoxic. But what is toxic is the vehicle in which it is used, which is cyclodextrin. And this is the same vehicle that is used in IV posaconazole or IV voriconazole. So except isobuconazole, many of the antifungal agents or the azoles that we use intravenously, like posaconazole or voriconazole, also have IV cyclodextrin. Now, interestingly, the cyclodextrin component of remdesivir is much lower than the cyclodextrin component of voriconazole and posaconazole. So animal models have shown that the nephrotoxic dose of cyclodextrin is actually, almost 7 to 10 times higher than the cyclodextrin dose which is used, or the content that is used in remdesivir. So that's why nephrotoxicity is not a huge concern. Now, many renal transplant patients and many renal transplant centers across the country are using remdesivir. Again, dialysis patients, we are using remdesivir. Right now, we are not really stopping remdesivir or preventing anyone from getting remdesivir because of the kidney numbers. If the patient develops AKI on remdesivir, then of course you hold it, because most of the times, again, it is reversible with cyclodextrin injuries. So again, it is not a huge concern at this point of time. What is concerning is that if someone has renal injury to begin with, and COVID-19 patients can have renal problems because of a variety of reasons. It could be the direct effect of the virus itself. It could be renal tubular acidosis, or these could be, originally diabetes and CKD patients, or hypertension and CKD patients. So if someone has renal impairment to begin with and you put them on remdesivir, cyclodextrin is likely to accumulate and cause hepatotoxicity and lower the threshold for seizures. So that is something that we need to keep in mind. But as such, we are not using any renal cutoffs for remdesivir. One of the concerns with remdesivir is, the mutations in the virus, because it's an RNA inhibitor. And we have seen with previous experiences, we have seen with flu, and we have seen with some of the previous RNA viral drugs, that the RDRP region of the virus can mutate. So, previously we have seen that favipiravir can induce, or a lot of irrational use of favipiravir can actually cause RDRP mutations. And these are first case reports emerging from Europe that we are starting to see resistance in the RDRP region. So will that be a concern? Till the time we have a pandemic going on, I don't think, we are going to be too worried about this, because of course, in a pandemic situation, we need to have protocols. But going forward, probably, in the next 6 months or 1 year or so, we'll have to absolutely decide, which patients we need to use remdesivir on. I think a blanket approach of using it in all hospitalized patients, we may have a price to pay for after 1 or 2 years. And these are not things that you see immediately in a pandemic. Coming to the monoclonal antibody cocktail. So what is this? This has been launched by Cipla at the end of May in India. So this is the monoclonal antibody cocktail. And again, while we are talking about direct viral agents, this is something which is new in the market now. So this is casirivimab and imdevimab, which are monoclonal antibodies. So these are artificial or monoclonal antibodies against the antigen binding domain, or ABD, of the COVID-19 virus. So where the COVID-19 virus attaches to the receptors, the antigen binding domain, we have now manufactured an artificial antibody against this. So it gives you protection for about 2 to 3 weeks from COVID-19. So it is in theory supposed to prevent attachment of the virus to its receptors, because it's a monoclonal antibody against the antigen binding domain. So this is against the spike protein. And again, this slide is not very clear, but so far there are 3 studies which have been done in this regard. So this is the original phase 1, phase 2 trial, and you can pull this up easily on AnyJM. This was published in the New England Journal in March of this year. What they showed was that compared to placebo, patients who received this monoclonal antibody, they had lower rates of emergency room visits, or subsequent ER visits were reduced. As you can see, probably from this figure, it's a little bit better. There was some reduction in the ER visits, but these were phase 1 and phase 2 studies. Then going over to the phase 3 trials, what we saw was that there was reduction in hospitalizations as well as ER visits. And again, these are phase 3 trials, and you can easily look them up on the US FDA website. So I'm not going to be spending a lot of time on that. But now we have data from the recovery trial, which actually showed that if you use a 4 gram combination of casirivimab and imdevimab, you might actually have mortality benefit from it. Now, there are certain concerns about this. One is that the cost of this therapy. So the cost of this therapy is enormous. For 600 milligrams, the cost in India is about 60,000 rupees. So if you have to really give someone the dose that they had used in the recovery trial, you will have to give this patient, a drug which is almost costing this patient 4 lakh rupees. Again, when do you use this drug? So as I mentioned, price and dosing is a problem. Who should get it? So currently we are using it in the first few days. So earlier the US FDA recommendation is to use it at diagnosis. Best used within 3 days, at least within the first 7 days, because as I mentioned, it's a monoclonal antibody which is targeted against the antigen binding domain of the virus. So the earlier you use it, the better it is. So as soon as you diagnose someone with COVID-19, you should think of using it, and use it in the high risk patients. So for example, patients who are unable to mount an immune response. So let's say I have someone with hypogammaglobulinemias, or I have a BMT transplant recipient. These are the kind of patients in whom you can use this monoclonal antibody. One of the interesting aspects in these trials was that patients who had antibodies to begin with did not seem to benefit with the usage of monoclonal antibodies. So for example, if I have taken both my doses of COVID-19 vaccine, I have a measurable IgG response. So my spike protein antibody IgG is positive, and then I get COVID-19. And we have seen that in a lot of patients, post-vaccine COVID infections. In these patients, if you already have a COVID-19 IgG to begin with, then the monoclonal antibody is not going to do much. So currently it is recommended for seronegative patients, which means that they are negative against COVID-19 antibodies to begin with, and in the first few days of the infection, and provided they have risk factors for progression. So I have a very obese patient who has a BMI of 35, uncontrolled diabetes, has ischemic heart disease, or a cancer patient who is on chemotherapy, elderly gentleman, and I'm worried that his antibody response against COVID-19 is not going to be that robust. Then these are the kind of patients for whom I can consider using monoclonal antibodies. As I mentioned, the mortality benefit dose is really worth 4 lakh rupees in India. So that we are not using it for any patients. In the recovery trial, and you can definitely look these things up. In the recovery trial, the mortality benefit dose was 4 grams. And interestingly, they had also used this dose in hypoxic patients. So in the recovery trial, 90% of the patients who were enrolled for casirivimab and imdevimab were actually patients who were admitted in the hospital with hypoxia. So that I feel is very interesting, which means that if you're contemplating using this in hospitalized patients, then probably you have to go for a higher dose at this point of time. So at this stage, most centers in India, how they are using it is that if you diagnose someone with COVID-19 in the OPD, and you think that this patient is at a very high risk for progression and has baseline antibodies which are negative, then you should give this patient 600 milligrams of casirivimab and 600 milligrams of imdevimab, which comes out to be 60,000. So once you open the vial is 1200. So if you open the vial, you will have to give half the vial to one patient. And if you can find someone else, if you can find a scheme of 1+1, if you can find another patient to give this vial to, then it is going to cost you 60,000 per patient. Otherwise, it will cost you 1,20,000 per patient. So we are right now not doing this in our daycare center. If at all someone gets casirivimab, imdevimab in Dinanath Mangeshkar Hospital, we are admitting that patient at least for 24 to 48 hours. And I don't think we have used it in more than 4 or 5 patients at this point of time. Again, there is potential for misuse, because there is a lot of cost involved. And once someone gets monoclonal antibodies, that person should not get vaccinated for the next 3 months. But anyways, right now with our government rules, we don't vaccinate patients after COVID-19 anyways for the first 3 months. So is there any real benefit for patients who have antibodies or are vaccinated? Probably no. Now coming to steroids in COVID-19. So these are the two direct antiviral therapies I wanted to talk about. I'm not going to be talking about, favipiravir or lopinavir, ritonavir, or, some of the other antiviral agents, HCQS and azithromycin. We can take that up during the Q&A, or probably Dr. Ramya will address that in some of her cases. So coming to steroids in COVID-19, there are important questions to be answered here. We all know that these are drugs that give you mortality benefit. But the real question is, for how long, what doses to use, which preparation to use. So, dexamethasone versus methylpred versus prednisone versus hydrocortisone. So which is the drug that you're going to pick? What is the starting point of steroids? So when are you going to start steroids on someone? And then I'll again share some of the evidences, and I'll share our own protocols on what we are doing. So this was the original study, and till we had the recovery study showing tocilizumab mortality benefit or monoclonal antibody mortality benefit. This is the only study to date in COVID-19 management which has shown mortality benefit. So this was the recovery trial last year, in which they showed that using 6 milligrams per day of DEXA for 10 days in UK, which is equivalent to 8 milligrams of DEXA in India, because we use a different preparation, confers mortality benefit to hypoxic patients. But I think every word of this sentence is important. What they showed was that using 6 milligrams for 10 days to hypoxic patients confers mortality benefit. And then subsequently, this is one paper that all of us who are dealing with COVID-19 patients should read. So this is the JAMA paper on corticosteroids from, I think this is from August last year. And this is a very elaborate study, because this is, a meta-analysis. And you will clearly see here that, what favors the usage of steroids and what does not favor the usage of steroids. So if you see, there are 2 or 3 very important lessons from this meta-analysis. One is that, all the studies are showing that low dose steroids are beneficial. So clearly, so if you see this diagram here, the more you go towards the right, you have data favoring steroids. And the more you are towards the left of this confidence plot, you have data showing that you don't benefit much from steroids. Now, if your data is in between, which means that it goes over from the left part of the diagram to the right, then also you're not very likely to benefit. So you see, there are only very few things which are clearly on the right side. And one of them is using low dose steroids. And the other is, using dexamethasone. So again, this is just the opposite. This is the mirror image. So favors steroids and does not favor steroids. So again, what they are showing is that DEXA, the evidence is stronger compared to methylpred, and low dose DEXA, the evidence is stronger compared to high dose DEXA. So again, if you take a look at this compared to dexamethasone, dexamethasone has stronger numbers than methylpred, and low dose DEXA has stronger numbers compared to high dose DEXA. So you'll see again, favor steroids is, the evidence is stronger in the low dose DEXA group. These are again, the equivalent properties of steroids. So not every steroid is the same. The steroids have different half-lives. The steroids have different anti-inflammatory properties. Now you can see from this that the anti-inflammatory property of DEXA is very, very potent. So which means that it is almost 5 to 6 times more anti-inflammatory than something like prednisone or methylprednisone. We also have to remember that it is much longer acting. So the half-life of DEXA can almost be 2 days. So the median half-life of DEXA is around 48 hours, which means that even after stopping DEXA, the next 3 or 4 days, the patient is subjected to some amount of steroid exposures. So these are important things that we need to remember. And that's why completely calculating the equivalent doses becomes a little difficult. So for example, if you apply the equivalent dosing formula, then 8 milligrams of DEXA is equivalent to, around 40 milligrams of methylpred. But if you look at the anti-inflammatory effect, then 8 milligrams of DEXA, something which is 6 times more anti-inflammatory, you can't just convert the dose of dexamethasone to methylpred. So that is why most centers across the world are using 40 milligrams BD of methylpred as equivalent dosing, which is actually, 80 of methylpred total, which is equivalent to actually 16 of DEXA in terms of the absolute dosage, but somewhat comparable in terms of the anti-inflammatory properties. So here also we use 4 milligrams BD of Dexa or 40 milligrams BD of methylpred. One of the important questions is duration, and we were talking about this on rounds yesterday. What we do here in-house is that we use steroids till the patient is hypoxic. So first and foremost, we don't use steroids in non-hypoxic patients, because if you see the original recovery trial, patients who were not hypoxic actually had higher mortality with steroids. So someone who comes to us, let's say with a CT score of 12, with a CRP of maybe 50 or 60, and is an elderly gentleman, the question is, should you start him on steroids? There are some centers in the country which are doing it. I must say that there is not a lot of data to support this practice. There was one paper last year from New York in which they had shown that, if your CRP is more than 20 versus if your CRP is less than 20, those patients who got steroids based on their CRPs, if they had higher CRPs, benefited. But apart from that, there is not much evidence. And in India, we are also paying a heavy price in terms of post-COVID mucormycosis and post-COVID infections. And again, if you make someone walk for 3 to 6 minutes, you are detecting early hypoxia. So you're not waiting for that patient to, be on a high dose of oxygen or a high requirement of oxygen before you're starting steroids. So at least here, what we do is that as we don't start steroids on non-hypoxic patients, regardless of the risk factors. As soon as they become hypoxic, which means that in the day, at least 3 or 4 times, you make them walk for 3 to 6 minutes. As soon as they become hypoxic, we start them on Dexa. And as soon as they are off oxygen for 24 hours, we stop Dexa. Now, sometimes what happens is that these patients keep progressing, which means that they never come off oxygen, even for the first 3 or 4 weeks, they may not come off oxygen. So they keep worsening. They go into the ICU, they get transitioned to NIV, they get intubated. Some of them, if they're lucky, they get extubated, come back to the floor, they're still on some amount of oxygen. So by the time they're completely off oxygen, for some patients, it might take 2 or 3 months. So then what do we do in those patients? So as we were discussing yesterday, what we do is that if someone has been on steroids for 10 days, the decision to continue steroids for that patient, rests with our pulmonology department. So usually what we do is off oxygen for 24 hours, off steroids. And if that patient continues to require oxygen for 10 days, then which means that he has been on steroids for 10 days, we get our pulmonologist to see them and decide long-term steroid usage. Because one of the important criteria for continuing steroids would be organizing pneumonias. So then coming to Totalizumab, again, we have had 3 important trials. One was the Covacta trial, then you had the Totalizumab arm of the recovery trial, and then you had the REMAP CAP study. So again, all 3 showed similar utility. And I think the recovery criteria are useful and convenient to use. So what they showed in the recovery trial was that Totalizumab reduced mortality, but in which patients? Eligible patients had an oxygen saturation of less than 92 on room air, or were receiving supplemental oxygen and had a CRP of more than 75. The median CRP in the TOSI arm of the recovery trial was in the 140s. Which means that, if you start someone who is hypoxic on steroids, and in the next 24-48 hours, if their hypoxia continues to worsen, you repeat the markers and they are going up, that is the time you consider further immunomodulation. So based on all the evidence that we have so far, really the 3 agents that you should consider in this situation are A, Tocilizumab, B, Baricitinib, and C, Tofacitinib. These are the 3 agents which have shown the best evidence so far. There has been very little evidence with things like Bevacizumab or Infliximab or some of the TNF-alpha inhibitors. So if you had to really use further immunomodulation, and I would also add Itolizumab to that list, usually your choice would be one of these 4 agents. So Itolizumab, Tocilizumab, or the JAK inhibitors. So that means that either you are considering using IL-6 inhibitors, or you are considering using JAK inhibitors, and we'll see some of the data. Secondary infections with Tocilizumab, has always been a problem. So initially, when the subcutaneous Tocilizumab studies came out, there were some patients for whom we tried using subcutaneous Tocilizumab. And again, this is old data. This is data from 4-5 months back. So at least the first 45 patients in whom we had used tocilizumab, the death rate as well as the secondary infection, which means candidemia or bacteremia in the next 14 days, seem to be comparable with IV tocilizumab or subcutaneous tocilizumab. So subcutaneous is given as injections of 162 milligrams on each thigh. So you give a total of 324 milligrams as a subcutaneous dose. The level that it reaches, the drug levels that are reached with subcutaneous doses are slightly lower. So there was this initial hope that, secondary infections might also be slightly lower, but at least in my experience, we haven't seen that. So again, there are a lot of controversies surrounding usage of tocilizumab. So when should tocilizumab be used? So I think based on the experience that we have so far, it should be used in patients who continue to be hypoxic, who continue to have a worsening inflammatory picture, and more importantly, you have ruled out secondary infections. So you do not think that there is an active fungal, bacterial, or a mycobacterial infection going on. They are not neutropenic and they don't have very bad transaminitis. So their liver functions are not more than 5 times the upper limit of normal. They are not neutropenic or thrombocytopenic because tocilizumab can worsen the cytopenias. And they are not actively infected with another agent apart from COVID-19. So usually what we do is on 24 hours of steroids, if the patient is worsening, we send CRP, ferritin, and procalcitonin, and maybe repeat imaging. If we are fairly certain that, clinically, radiographically, and markers wise, this patient is unlikely to have a secondary infection, that is the time we use tocilizumab. Most centers in the world are moving away from second doses of tocilizumab because the first dose itself is controversial. I don't think right now there is a huge role or real clarity on the second dose of tocilizumab. So that is something, I have put in red. Maybe it should be, sort of discouraged. But what really should not be done is post-tocilizumab IL-6 levels. Now, I have seen IL-6 levels being done after giving tocilizumab. We have to remember that tocilizumab can actually increase IL-6 levels because it's a monoclonal antibody. It's a monoclonal agent that blocks the IL-6 receptors. So by feedback mechanisms actually produces more IL-6. So we are blocking the IL-6 receptors, but the body tries to produce more IL-6. So that's why the end result is that you have increased IL-6 levels. But because what happens is that sometimes after the first dose of tocilizumab, the patient is still worsening. You send repeat IL-6 levels, they have gone up. So you give him another dose of tocilizumab. That is not what should be done. You are expected to have higher IL-6 levels after giving tocilizumab. We talked about IV versus subcutaneous. One important thing is it should not be used simultaneously with baricitinib. That's very important. So this is our colchicine experience again, in patients in whom we are not very sure that they have a secondary infection. We are using colchicine. I don't think it is very, very effective. It does seem to reduce, the CRP and ferritin to a certain extent, but of course not as potent as tocilizumab. So these are our CRP and ferritin reductions, colchicine versus subcutaneous tocilizumab. We have just observed this for about 50 patients in the beginning of the pandemic. These are 2 studies with colchicine. Again, I'm not going to go into the details of that, but please look them up. So Colcorna is a study which showed that colchicine reduced the death rate in hospitalized patients. And then you had this Greek study or the Greco-19 study last year, which showed that colchicine was somewhat beneficial. So again, if I'm not sure, so CRP ferritin is going up, but I'm not sure whether this patient has a secondary infection. These are the patients that I put them on colchicine plus antibiotics. This is some data from baricitinib trials. So again, probably I'm running out of time, but baricitinib, we use it in similar settings like tocilizumab. So there is now growing evidence that patients on steroids also can benefit from baricitinib. So again, similarly, its role is similar. It's a JAK-STAT inhibitor. So there are different JAK pathways, JAK 1, 2, and 3. So there are slight differences in baricitinib and tofacitinib and ruxolitinib, but baseline they are all JAK-STAT inhibitors. So what we are doing is that patients who again continue to progress on DEXA, we are considering baricitinib. The hope is that secondary infections with baricitinib will be fewer than those with tocilizumab. So again, it may be used as a steroid sparing immunomodulator, but that I personally don't because mortality data with steroids is robust. Combining it with steroids in select patients, maybe using it as a tocilizumab sparing agent. And again, the same thing with tofacitinib. I hear that, you have had a decent experience with tofacitinib, so maybe we'll take that up. 2DG, I mean, personally, or very little knowledge about this product. So again, this is all that I had. So I'll hand it over to my fellow. She's going to just present 2 or 3 representative cases, and then we'll take up questions if there are any. Thank you.
Where are the slides? There only will make. Sir, कौन सा है? This is sir's no. Oh, sorry. What happened? हाँ. This is sir's. Yes, sir. Yeah. Evening. Am I audible?
Yes, ma'am.
Namaskara. I'm Dr. Ramya. I finished my DNB and now I'm doing my fellowship in infectious diseases under Dr. Parikshit Prayag. Thank you, sir, for this opportunity. So I'm giving an overview of 3 cases I randomly picked up in our COVID ward. So this is the first case. So she's a 25-year-old young female with no known comorbidities. So she presented to us with dry cough since 2 days, fever 1 day, generalized weakness. She was COVID antigen positive, and other than that, she was clinically preserved. So we did day 1 labs that showed CRP of 3.6, LDH of 150, ferritin of 95. Her D-dimer was 294 and random blood sugar was 92, and CBC and chest X-ray were within normal limits. So her treatment included only symptomatics that includes vitamin C, zinc capsules and paracetamol SOS for fever, and we called her for regular follow-up with the home monitoring protocol that includes any persistent high-grade fever, cough or breathing difficulty, and fall in saturation less than 94%. Now she's doing well. Case 2. This is a 35-year-old male who presented on day of illness 10. He was COVID positive by RT-PCR. His complaints were breathing difficulty and cough. There was no fever. Hypothyroidism on medication. On presentation, he was having saturation of 87% on 4 liters of oxygen. So with 10 liters, he was maintaining 95%. So his HRCT was done that gave us a score of 12 out of 25. So the labs which he had done on OPD basis outside showed D-dimer of 130, ferritin 96 and IL-6 of 32. His CBC was unremarkable. So after this, after seeing the reports, being hypoxic, he was initiated on dexamethasone 4 mg BD, ecosprin, vitamins, ceftriaxone and doxycycline. So after we repeated the labs at Dinanath, his RFT and LFT were normal, CBC was normal limits, ferritin was 1000, CRP was 137, D-dimer was 259 and his procalcitonin was negative. So a diagnosis of storm was made and he was injected with Totalizumab, 400 mg IV infusion over 1 hour, and labs were repeated after 2 days that showed that CRP has come down to 28, D-dimer remained 175, procalcitonin yet negative. So this patient has been discharged on home oxygen and he was needed oxygen until discharge. After that, he maintained saturation in room air and he's been discharged home without any oxygen support. He has come for follow-up and is doing well. Case 3. This is a patient who's admitted, is an inpatient right now. He 36 male with no comorbidities. He has come on 12th day of the onset of symptoms. He was tested positive on 10th of July and CT chest was done on 11th of July, showed a score of 6 out of 25. So he was admitted outside for fever, breathing difficulty, has received remdesivir outside. And after receiving remdesivir, he was found to have persistent increase in oxygen requirements and has been referred to Dinanath for further management. So review of labs done outside shows that CRP was 3.8, WBC was 19,500, D-dimer of 849, and repeat labs done in Dinanath shows that the CBC shows persistent leukocytosis, 17,000 total count. D-dimer of 458, and CRP was 5. His RFT was with the normal limits. HRCT repeated showed some GGOs and some consolidation and effusion. So this areas of ground glass densities with interstitial thickening and GGOs were found, along with some consolidatory changes with mild effusion and thickening. So a diagnosis of secondary bacterial infection or pneumonia was made, and he has been started with piperazolone tazobactam, Clexane 60 BD, and Dexa 4 mg BD in view of hypoxia, and his sputum studies are awaited. So thank you. Do we have a Q&A session which we would want to start now, or should we schedule it later? Should we address any doubts to sir? Any questions or anything do we like to discuss, or can we call it a day? If there's anything, we can always reschedule later. Okay. Thank you, sir. Thank you all for this opportunity.
You were saying something.
It's still there. Okay. Okay. Vote of thanks, sir. Stop हो गया है. It's stopped here, but it's stopped here, no? Okay.
We can log on to our group.
Okay.
Thank. Hello. So, am I audible, sir?
Log into Jesus. Santosh,
Ma'am.
are you able to hear us?
Yeah, ma'am. Yeah, ma'am.
You have any one of you have doubts? Santosh?
Hello, ma'am.
Yeah.
No any doubts from our side, ma'am. Just we'll call for the day.
Yeah.
Sure, I thank you so much for Dr. I thank you so much, Dr. Parikshit Prayag, sir. So now I would like to call Dr. Sujay to give a note of thanks for this event.
Good evening to all. First, I would like to thank all the doctors, nursing staff, and supporting staff who worked tirelessly during the last two ongoing pandemic COVID-19. I thank Dr. Parikshit Prayag for enriching our knowledge on the effective management of the COVID-19 pneumonia. Thank you for your contribution towards this pandemic. I thank everyone who attended this informative event. Finally, let's hope that this crisis will be resolved in the near future. Thank you all.
Okay. It was really wonderful. Actually, मुझे वो ड्रग्स का really it was very helpful.
But we need much more, like corrector and all.
Sure.
I need it. So what we can do is, what we can do is have